Low back pain is a serious problem in the world and it's a leading cause of pain and disability. As a physio, we see a lot of back pain patients every day in our clinic, and this back pain constitutes almost 80% of our caseload. As a physio, we always try to diagnose what is the reason for the back pain, whether the back pain is due to discogenic or facetogenic, or is it coming from the neural source, or is it coming from the bone itself. So, diagnosis is very important. But before making a diagnosis, one should be very well versed in the anatomy of the back, because the structure decides the function and function influences the structure. So without knowing the fundamental understanding of what structure constitutes the back, it's difficult to make a diagnosis. So in this video, I'm going to talk to you about the basics of the anatomy of the low back. So it makes some sense to you when the patients say you that they have a back pain. So we have about 33 vertebrae in the body. In that, we have 5 lumbar bones. So lumbar means the lower back bones. So we have L1, L2, L3, L4, L5. So they are the one which takes majority of the body weight compared to the cervical and the thoracic spine, and that's why the lumbar spine bones are pretty big and massive compared to the cervical spine or the thoracic spine. And we have the anterior column, which is made up of the bone and the disc put together. We call that as an anterior column. So the bone here, we call that as a vertebral body. The vertebral body with the adjoining disc. So this constitutes the anterior column of the spine. And we have the posterior column of the spine, which is composed of the spinous process, the lamina, the transverse process pedicle, and the spinal canal itself. The spinal canal is the space through which the nerves will be passing through. Okay, the line of gravity passes slightly posterior to the lumbar spine. So that's why there must be a slight lordotic curve for all the human beings, and this lordotic curve makes sure that the weight is transmitted mostly into the posterior aspect of the vertebral body. But whenever someone is bending forward or when someone is slouched in a sitting posture, the line of gravity will be shifting anteriorly, putting the pressure on the disc here, and that disc can in turn get compressed front, that squeezes some of the materials backwards. Okay, so that's why majority of the people who have pain will have pain coming from the anterior column of the spine. Why? Because 80% of the body weight will be passing through the anterior column of the spine. Remaining 15 to 20% of the body weight will be passing through the posterior column of the spine. So the posterior column has a facet joint. Okay, so that's the reason why facet joint is only taking less body weight, because it's located in the posterior column. The vertebral body, the disc, they're all massive and they are designed to take the majority of the body weight, and that's why the problem also is more in the anterior column. Joint between the vertebral body and the disc is called as intervertebral joint. It takes majority of the body weight and helps in weight distribution and weight transmission. Okay, so things can go wrong here. The disc itself can get degenerated, it can get bulged, it can get sequestrated, and it can go compress the nerves behind, causing sciatica pain. It can cause end plate fractures. Disc is interposed between two bodies, and the end of the vertebral body is called as end plates, and that end plate can get broken, and some of the disc material can go off, causing small nodules. So these are some of the variations of the pathological changes happening in the spine that can be the cause of the pain. Okay, but the patient will know only pain. They don't know why it is painful, and everybody are looking for pain relief, pain relief, pain relief. So without knowing what is causing the pain, don't do anything for the pain relief, because pain relief is just going to be a temporary phenomena without knowing what is causing the pain. So as a physio, we always have to go to the source of the pain and treat the source, so that the pain will be looked after itself. If you treat only the pain, then it's like a temporary relief. You will not get any long-term results. Okay. Coming to this view here, what you can see is the vertebra, and we have removed the posterior column. We have removed the spinous process and the lamina to expose you the nerves, which is called as cauda equina nerve. The reason why it's called as cauda equina is it looks like a horse tail. Now the nerves will be projecting downwards like a horse tail like this, and at each level, two nerves will exit between the spine. So at L5 S1 level, the L5 nerve will get exited. At L4 L5 level, the L4 nerve will get exited. So when someone has a compression of disc at L5 S1 level, it can compress either the exiting L5 nerve, or it can compress a transversing S1 nerve. So that's why mostly in L5 S1 disc bulge, people will have pain in in the in the thigh, in the calf, or in the foot level. Okay, it's because at this junction we have L5 nerve that can get compressed, or S1 nerve that can get compressed. If you see this view, this is the cross section of the spinal cord itself. What you see is the anterior horn or anterior gray horn. This is the posterior gray horn. The anterior gray horn is nothing but amalgamation of the motor nerve nucleus. The cell body of all the motor neurons are located in the anterior horn. So this is mostly representing the motor aspect. This is mostly the posterior gray horn represents the sensory aspect. So the motor is always efferent. From the anterior horn cells, the impulses will be going downwards via the alpha motor neuron to govern the muscle contractions. Whereas the sensory one is coming from the peripheral receptors, and it passes through the sensory nerves, and then it goes to the posterior root, and then it converges the information to the posterior horn. The anterior is motor and the posterior is sensory. A root which is starting from the anterior horn cell is called as anterior root, otherwise called as ventral root. The root which is going to the posterior horn cell is called as posterior root, or otherwise called as dorsal root. So in each segment of the spinal cord, we have an anterior root or the ventral root and a dorsal root, and these two roots join together, and then it forms as a spinal nerve. At this level, the spinal nerve is a mixed nerve, which constitutes both impulses from the anterior root and impulses from the posterior root. So that's why it's called as spinal nerve, because it is at the junction where the nerve is exiting from the two vertebral bodies. The dorsal root, which is carrying the sensory fibers, before it reaches the spinal nerve level, it has an area called dorsal root ganglia. The dorsal root ganglia is the area where we have the nucleus or the cell body of the afferent neuron. So for the motor, the cell body is located in the anterior gray matter. For the sensory, the cell body is located in the dorsal root ganglia. That's why the dorsal root ganglia is an important structure. We call that as a mini brain of the afferent nerve. From there, it becomes like a mixed spinal nerve, and that spinal nerve will divide into two rami. One is anterior rami, other one is posterior rami. So the anterior rami, if it is in the lumbar level, it forms lumbar and lumbosacral plexus. The anterior rami, if it is in the cervical level, it forms cervical plexus. Okay. In the thoracic level, it doesn't form any plexus. And the dorsal rami, which is one more branch of spinal nerve, will go backwards and innervate the erector spinae muscles and other smaller ligaments and the spine there and the area of the skin too. So the dorsal rami is small in size because it doesn't govern too many muscles compared to the ventral rami, which governs large muscles of the legs and the foot and ankle and so on. Okay. So in the anterior horn level, it is motor. Anterior root or ventral root is motor. Spinal nerve is mixed. Anterior rami, which is a part of spinal nerve, is also mixed. The posterior rami is a part of spinal nerve, is also mixed. So the dorsal root is afferent. From the receptor level, the sensation will go above to the spinal cord, that is called as afferent. So the impulses will go from down to up is called as afferent. The impulses which go from up to down is called as efferent. Okay. Now, in pathology wise, the lesion can happen in multiple levels. The lesion can happen in the root level, which is here. The lesion can happen in the spinal nerve level, which is here. The lesion can happen in the rami level, which is here. The lesion can happen in the plexus level. Conditions like neuralgia or plexopathy, brachial plexopathy or lumbar plexopathy, the lesion will happen in the plexus level. Okay, so we need to identify where the level of lesion is so that we can give a right intervention. Okay, so in disc bulges, let's say this is a single spinal nerve. When there's a L4 and L5 disc level is bulging, it can touch the L5 nerve, which can touch maybe here or maybe here, or maybe it can touch the spinal nerve itself, or in rare case scenario, it can touch the dorsal root ganglia itself. Once the disc is touching the dorsal root ganglia, and the pain will be very, very severe, because the dorsal root ganglia, as I mentioned, it's one of the mini brain, so it cannot take any sort of compression or the chemical changes within itself that can cause serious pain to the patient's corresponding nerve. Okay. So this is the basic understanding that every physio must know when they are dealing with pain, especially when the pain is coming from the neural source or the spinal source. We need to ascertain which level the pain is there, or how the pain is emanating from the given structure. Is it a mechanical pain or is it an inflammatory pain? So before we do all these things, so this basic understanding is necessary so that we can be confident in assessing the patient, so that we can give a right intervention. Okay, I hope this video is a bit helpful to you. Thank you.